Bismillah ar-Rahman ar-Rahim. Welcome to ERA. I'm Dr. Muhammad Talat, Assistant Professor at Cairo University. Today, I have a very interesting case, and at the same time, it is a challenging case. I think it is very rare to see this case on the emergency situation, but it can be happen. So let's concentrate and let's start to pick up the abnormalities. This is a pediatric patient, and she came to the ER multiple times with different focal neurological deficits, sometimes twitches in the upper hand, sometimes abnormal gait, and all the time she was managed by medical treatment. But the last time, one of the physicians requested to do CT brain for her. She is 15 years old, and let's start to pick up any abnormalities. Once we have a focal neurological deficit, we should search for any ischemic insult. Really, I don't have any gross ischemic insult, but we will check also the stroke window. We don't have any significant cerebral edema. Also, we don't have any evidence of vasogenic brain edema or space occupying lesions. We don't have any hemorrhagic insult. So we couldn't pick up any gross abnormality. But really, I have a concern at this area. I'm not sure if this one is rare or not. Ill-defined small hypodense area at the white matter. Also, maybe something like hypodense area at the centrum semiopen. Really, I'm not sure are these abnormalities are real or not. Let us see, maybe this one for a little bit more obvious at the left temporal region, this area. I think there is something abnormal in the white matter, multiple ill-defined hypodense patchy areas. Really, I started to use my checklist. I don't have any mass effect at the cortical sulci. We don't have any extra-axial collections. We don't have any space occupying lesions. Even our checklist include the gray white matter interface. I think we can discriminate very well the gray matter from the white matter. So we don't have any loss of the gray white matter interface. Let's go more to the white matter. Let's change our window to make it for a little bit stroke window. I know that the stroke window is noisy, but sometimes it is helpful. I think now it's more clear to have something here. Periventricular invocation. Also, this one is more obvious now. And also this area is very obvious. So for me, at the time, there is something wrong in the white matter. I couldn't pick up any more abnormalities. Really, these areas are non-specific finding. How can we think together? What are our differential diagnoses? I know that our differential diagnosis is a CT image or CT exam. It's very broad, but let us think together. What is our differential diagnosis? First, maybe something like vascular, maybe vasculitis, maybe CADA-cell. CADA-cell, it's more, or its peak in the middle age and adult patient between 30 to 50. CADA-cell, maybe vasculitis. So CADA-cell is far away, maybe vasculitis, maybe white matter disorder, maybe demyelinating. Demyelinating means that there is a damage for the normally myelinated structure. The demyelinating include MS, also ADEM. Maybe dismyelinating disorder. Dismyelinating means abnormal structure and function of the myelin itself, most likely due to hereditary disorder. But I think it is far away to be leukodystrophy or this dismyelinating disorder, because this age group is very rare to have leukodystrophy at that time, at this age group. I know that there is an adult onset for leukodystrophy sometimes, but really it's very odd to see multiple widely scattered white matter changes like this one. So I think we can also add cortical and subcortical tumors, as we see in tuberous sclerosis, maybe something like hamartomas. But really, when I started to search for any subepidermal nodules, I couldn't pick up any subepidermal nodules. Also, the clinical manifestation is very different. We don't have any history of epilepsy, something like this. We have a recent onset of multiple acute neurological deficits within 2 or 3 weeks. When I asked the relative, the father of the patient, he said that the child complained of a viral illness 3 weeks ago. So I put ADEM in my differential diagnosis, also MS and vasculitis. Those are more commonly in my mind at that time. I think I wrote the report and I recommended to do MRI exam. Really, I was very excited. What is the diagnosis? What is the possibility in this case? And really, I pushed to do the MRI exam at the same day. Let's see together what did we find in the MRI exam. We did MRI exam for the patient, and really, I was surprised by multiple white matter lesions located at the frontoparietal regions on both sides, bilateral asymmetrical, having subcortical and periventricular locations. And really, the lesions show perpendicular orientation to the ventricular system. This is the ventricular system, and we have perpendicular orientation to the ventricular system, as you can see here. And these lesions display high signal intensity in T2 and flare images. Also, the left temporal lesion is very obvious in MRI exam. We have also a similar lesions involving the left middle cerebellar peduncle, and also the posterior aspect of the bones, right paramedian location. Also, the left occipital region shows similar lesion as well. In the axial T1 weight image, the regions are partially indistinct. Just we can see some of these lesions, and these lesions display low signal intensity in T1 weight image, and other lesions are iso-intense as compared to the normal signal intensity of the brain tissue. We have also the lesion that is located at the left middle cerebellar peduncle. It displays low signal intensity. The pontine lesion appears almost indistinct. Let us review the diffusion with image and the ADC map. Really, the right-sided white matter lesions show facilitated diffusion. We don't have any evidence of restricted diffusion. The left side white matter lesions, some of them show facilitated diffusion, while this small lesion show evidence of restricted diffusion in terms of high signal intensity in the diffusion and low signal intensity in the ADC map. Also, the pontine lesion shows an evidence of diffusion restriction. So we have almost 2 lesions show evidence of diffusion restriction. Otherwise, the rest of the lesions doesn't show significant diffusion restriction. The saturative T weight image shows very clear small lesion involving the body of the corpus callosum. Also, the splenium is affected. The pontine lesion is very obvious. The scanned upper portion of the spinal cord is free. Even the callosociptal interface here is affected. Also at this area. So in conclusion, we have multiple white matter lesions with abnormal signal intensity. Some of them show evidence of diffusion restriction. And also we have some lesions involving the corpus callosum, brainstem, and the middle cerebellar peduncle. And most of the lesions, or most of the white matter lesions, show perpendicular orientation to the ventricular system. I think all of you now can make a narrow differential diagnosis. Mainly, we are thinking of multiple sclerosis versus ADEM. The orientation and the distribution is more with MS, but also the pediatric onset is more with ADEM. Let's focus how to differentiate between MS and ADEM. Regarding the age group, MS is involving adults more than pediatric. Even we have a pediatric onset around 16 years old or below. ADEM is involving pediatric age group more than adult. Clinically, MS is presenting with polyphasic disease. Polyphasic means recurrent attacks of neurological deficits. ADEM most likely monophasic, not polyphasic, and in many times it is preceded by a viral illness. The classic scenario is the child had a viral illness followed by ADEM manifestations. Regarding the sites, the white matter lesions in the MS is perpendicular. Most likely you can see or you can pick up some lesions perpendicular to the ventricular system. And this one has a very nice explanation. MS or demyelinating plaques involving the medullary veins, and the medullary veins have a perpendicular orientations to the ventricular system. So MS is involving or making demyelinating plaques around the medullary veins, and this one is obvious as perpendicular to the ventricular system. In ADEM, it is widely scattered. Regarding the corpus callosum and callosociptal interface, this one is more likely to be MS, while it is very rare to be affected in ADEM. Basic ganglia and salami rarely affected in the MS, while it is more commonly affected in ADEM. Brainstem and cerebellum are both affected in MS and ADEM, but for a little bit more in the MS. So let's apply to our case. It is polyphasic, and it has pediatric age group, maybe with ADEM. But we have a very classic morphological features of MS, white matter lesions perpendicular to the ventricles, and sometimes gives Dawson-like fingers, and we have Dawson-like finger in our case. Corpus callosum involvement and callosociptal. Basic ganglia and salami are spared. Brainstem and cerebellum are affected. So according to our morphological features, I think MS is suggested more than ADEM. Unfortunately, we couldn't inject the patient contrast at that time because the patient was not prepared at the same day, but we recommended to do contrast enhanced MRI study. Regarding the post-contrast series, MS mainly show ring enhancement if we have any activity, sometimes open arc or incomplete ring. And we discussed this point in one of our previous videos, that the ring will be opened laterally. Sometimes MS or demyelinating plaques show solid or nodular contrast uptake, while ADEM show patchy contrast enhancement and sometimes solid or nodular contrast uptake. Those are the main differential points to differentiate MS from ADEM. We have McDonald's criteria. This criteria is very important to suggest multiple sclerosis. We have 4 main locations: cortex, subcortex, periventricular, and centrum semioval, corpus callosum and callosociptal interface, brainstem, cerebellum, and spinal cord. Those are the 4 main locations for multiple sclerosis. To suggest multiple sclerosis, you should have at least involvement of 2 out of these 4 main locations. So once we have multiple lesions involving at least 2 out of these 4 main locations, so you can suggest multiple sclerosis. In each location, you should have at least 1 lesion that measures about 3 millimeter or more in maximum dimension. So according to the locations, we have these 2 main criteria, and this one is called dissemination in space. Dissemination in time means that if we have a baseline study done, for example, 2 weeks ago or 1 month ago, and we have follow-up study, and between both studies, we have some new lesions appear in the new study, or some of the old lesions appear partially obscured or disappeared in the new study. So we have changes between the old and the new studies between an interval time. This one is called dissemination in time. To apply to our case today, we had multiple follow-up for the case, and we detected dissemination in time. There was a new lesion, and some of the old lesions appear partially obscured. So we have both criteria, dissemination in space and dissemination in time, and the case was proved as multiple sclerosis. I want to ensure some important tips regarding the protocol and selected sequences. We should ensure that we are using FLAIR image, especially 3D FLAIR image. This one is more sensitive than the T2 wet image in the supratentorial brain tissue structures, while T2 wet image is more sensitive than the FLAIR image in scanning the posterior fossa structures, brainstem, and cerebellum. Those are very important. Also, such the T2 wet image is very important to assess the corpus callosum, brainstem, and scanned spinal cord. Corona T2 wet image is very important to assess the optic nerve. Optic nerve, in some institutes, consider this one as a 5th main location for multiple sclerosis, and multiple sclerosis is considered one of the most important causes for optic neuritis. So as much as you can, if you can diagnose or exclude optic neuritis in any case of multiple sclerosis, it will be more helpful. We have some bad prognostic values regarding the morphological features in multiple sclerosis. Once we have demyelinating plaques with low signal in T1 with image, also brain atrophic changes, iron overload, this one, we can detect this one by using SWI. Those are considered as bad prognostic values. If we need to determine the MS activity, we can depend on the diffusion restriction in case that we couldn't inject sufficient contrast medium. Contrast enhancement, this one is a standard. This one is the most important criteria of multiple sclerosis activity. Also, if the demyelinating plaques exerts any mass effect upon the surrounding structures, this is considered also one of the criteria of MS activity. By the end of this session, I would like to thank you all. I hope you enjoyed our case today, our challenging CT brain case. The MRI study was easier. I hope you enjoyed our tips, and have a nice day. Thank you so much.